All right. Let's see. Environmental emergencies. Oftentimes we just think of environmental emergencies as things like hot and cold emergencies. But the environment can be a very dangerous place. There's things like drowning. There's things like high altitude sickness. There are things like snakes and spiders and so bites and stings and those sort of things that also are considered environmental emergencies. We're going to talk first about heat loss and how your body loses heat. We know that your body makes heat or generates heat through metabolism. The byproduct of creating energy is heat. And if we don't have a way to dissipate that heat or get rid of that heat, we can suffer heat emergencies. But oftentimes, as is the case, we dissipate heat faster than we can produce it, and we can end up with hypothermia or cold body. So how the body loses heat, one of the methods is through conduction. And conduction is when you come in direct contact with a surface that is colder than your body. You can feel that. You touch any surface that's cooler than you. You can feel the coldness of the surface, and if you leave your hand or whatever there long enough, your body attempts to bring that surface temperature up to your temperature. So you can lose body heat through conduction. You can lose body heat through convection, and that's where air or water carry away your body's heat. The simplest way to think of convection is, blowing on a hot cup of coffee or blowing on a hot soup in order to cool it down so that you can eat it. Also remember that moving water pulls heat off your body 32 times faster than moving air. Radiation is when heat is picked up by the surrounding air or water. You radiate heat off your body, and you experience this when you first go into a room full of people that's relatively chilled, but after you close the doors and people have been sitting there as like little biotherms radiating heat off their body, the room warms up. So you can lose body heat by radiation. Evaporation is probably the most efficient way that your body dissipates heat, and that occurs when you sweat or when you get wet. As water evaporates off your skin, it pulls with it a tremendous amount of heat. But the thing to keep in mind about evaporation is that heat dissipation by evaporation ceases when you have high humidity. So when you get in environments where the humidity is greater than 80%, the ability to dissipate heat by evaporation of sweat stops. Now you also lose body heat when you breathe. Certainly put your hand out in front of your mouth and exhale, and you can feel the warm, moist air that you exhale every time you breathe. So here's just a diagram of the mechanisms of heat loss. So if you're being exposed to all of these at once, you have to be able to generate enough heat to keep your body temperature relatively normal. Your body doesn't function well outside a couple of degrees one way or the other of 98.6. Now, hypothermia occurs when your exposure to the cold reduces your body heat, or when your body is unable to maintain the proper core temperature. You get rid of heat faster than you can produce it. Now, it may lead to death if you get cold enough. There are predisposing factors that make you more susceptible to hypothermia. They include injuries. If you're injured and you can't move, and you lie on the cold ground, that will suck the heat right out of you. Moving, as you know, moving particularly large muscles like in your legs and your upper arms, moving those large muscles generates heat as well. Chronic illness or other certain conditions, particularly like taking medications, beta blockers, medications that people take to help keep their blood pressure low or to help keep their heart rate slow affect your ability to manage your temperature as well. Pediatric patients, geriatric patients, all are more prone to hypothermia. Geriatric patients are more prone to hypothermia because their internal regulator, their internal thermostat doesn't work as well, and so they have difficulty maintaining their body temperature. And children, in addition to having their metabolic rate is higher, they metabolize faster, they produce heat faster than we do, but their body surface area of all their skin is much larger than their mass ratio or their body weight. As a result, they have a whole lot of body surface when you expose them to the environment that can cause their temperature to drop suddenly. Other conditions that certainly may cause hypothermia include alcohol ingestion. When you ingest alcohol, your vessels have a tendency to dilate, putting the blood out here in the periphery so it can dissipate heat faster. If you've got underlying illnesses, you may not be able to generate heat as well or store heat as well. Overdoses or poisoning, major trauma, outdoor resuscitation. What we mean by that is that, when we're resuscitating a patient outside or even in the emergency department, we remove their clothing, so we expose them to the environment. We put cold oxygen in them. We put cold IV fluids and those sort of things in them, which help drives the temperature down in our resuscitation patients. And then just being in an environment that's cold certainly increases your risk of hypothermia. Now, hypothermia can occur anywhere, anytime, any place. Anytime or any place. We often think of hypothermia as occurring only in the wintertime or only in those environments where it's bitter cold. But in the dead of the summer, on a summer night that's 72 degrees, if you're injured and lying in a ditch, you certainly can become hypothermic. So anytime the environment is less than 98.6 degrees, there's a risk of becoming hypothermic. We've all experienced getting out of a shower or climbing out of a swimming pool or a pond and get the shivers. That's mild hypothermia. So a geriatric note here, I'd already mentioned that the effects of cold temperature on older adults are immediate. They don't have the ability to generate heat as fast. During winter months, older people live in small, on small fixed incomes, live in unheated rooms or rooms that are kept too cold. And you add the cold environment plus the slowing of the body systems and the lack of activity, which generates heat, leads to overall hypothermia. Again, pediatrics with infants and young children, they're very small, but they have a large skin surface area, which makes them more prone to hypothermia. And younger children, particularly newborns, are unable to shiver much due to their small muscle mass. When we shiver and we move those large muscles, we can generate quite a bit of heat. Shivering is an indication of early hypothermia. As you continue to get colder, you may become numb or have reduced or lost sense of touch or feel. As you continue to get colder, your muscles may become stiff or rigid. As you continue to get colder, you become drowsy. Your breathing may increase or may slow. Your pulse may increase slow or be unable to be detected because you are so cold. In the early stages of hypothermia, it's said that people get the umbles. They mumble, they grumble, and they stumble. And for most of us, that sounds like our elder population. So if you've got an older person who's mumbling, grumbling, and stumbling, and that's new for them, they could be hypothermic. So it would be it'd warrant you taking their body temperature. You also lose motor coordination as you get colder. Again, your joints and muscles become stiff and rigid. Your level of consciousness becomes decreased to the point of unconsciousness. Your skin becomes pale, waxy, cold, and may even be cyanotic. Now, there's two ways of rewarming people who are cold. One is called passive, and the other is active rewarming. Passive rewarming is what we shoot for in the pre-hospital environment. That's to prevent any further heat loss. That's to allow the body to gradually warm up on its own. And we do that by removing any wet clothing that the patient may have and cover them with dry sheets and blankets. Now, active rewarming can be dangerous in the pre-hospital environment, particularly in patients that are really cold, temperatures less than 88 degrees Fahrenheit. Active rewarming requires us to place hot packs in the groin, along the sides, top of the head, around the neck. Hypothermic skin can burn easy, even with a hot pack. So if we're going to use hot packs and apply an external heat source, we need to make sure that we cover the hot pack with a towel before we place it against the patient's skin. The other thing to keep in mind is that, as we rewarm the body, if we do it too quickly, patients can suffer a condition called afterdrop. Where all that cold acidic blood out here in the extremities ends up back in the core or the central circulation and can cause cardiac arrest. So extreme hypothermia, the patient is unconscious. It's very difficult to obtain vital signs. They're very cold to the touch. You may or may not be able to palpate a pulse. And in those cases, if there is no pulse, you want to go ahead and start CPR and hook up the AED. And the AED may not advise you to shock, or it may say shock advised. Just follow the AED prompts. If a pulse is present, care for the patient as you would any patient who is unresponsive. Begin with passive rewarming and getting things like pulse oximetry is going to be very difficult because their skin is really cold. So begin passive rewarming, control hemorrhage, splint fractures, all those sort of things. There's an adage in the business concerning extreme hypothermia, and that's you're not dead until you're warm and dead. And that literally holds true, that if I have a patient whose temperature is less than 88 degrees, and they have no vital signs, I need to resuscitate them till I get them warm. And if they still remain dead, then they're dead. But you're not dead until you're warm and dead. Now, localized cold injuries are frostbite. They most commonly affect the ears, the nose, the face, the hands, the fingers, and the feet. They result from tissues freezing. The water in the tissues may form ice crystals, which destroy the cells and cause them to die. Another common localized cold injury is trench foot, as a result of having feet submersed in cold, wet environments for long periods of time. The skin begins to break down, and you have limited blood flow to the feet, and cells begin to die that way as well. Early localized cold injury is called frost nip. And in those situations, you just need to remove them from the cold and cover them up. Late or very deep frostbite often leads to death of tissue and may lead to eventually over time amputation of tips of digits or earlobes or tips of the nose as a result of dead tissue. So here's an example of some frostbitten fingers after they had an opportunity to warm up. In caring for a patient with hypothermia, remove all their wet clothing, Actively rewarm the patient during transport. Now here they're saying actively rewarm them, and that really depends on the severity of the hypothermia. We definitely want to prevent any further heat loss. If the patient is in mild or moderate hypothermia, it would be okay to, to bundle everything up, maybe include some warm fluids to drink if they're awake and can swallow. But if they're really cold, less than 88 degrees Fahrenheit, we need to consider just covering their core, leaving their arms and legs out, and not giving them anything to drink, because certainly with a temp less than 88, they're going to be unresponsive. You want to transport these patients with hypothermia to the hospital unless, of course, it's mild hypothermia. If the patient is unresponsive, treat them like you would any unresponsive patient. Open their airway, high concentrations of oxygen. If you can warm and humidify it, that would be better, but very few services have that ability to provide warm, humidified oxygen. And then wrap them in blankets, and again, wrap the whole body in blankets, or consider just wrapping the core and leaving the arms and legs out if they are severely hypothermic, and then transport them to the hospital. If I've got a frozen part, actively rewarming that is seldom recommended because we could cause a permanent injury. If medical director instructs you to rewarm a frozen digit, a frozen hand, a frozen foot, mainly because you're perhaps hours away from care, then that might be something you consider. But we don't put them in hot water. We just put them in warm water in a container in which you can immerse the entire injury site, so that the site dangles in the warm water. We don't want them putting pressure on the sides, top or bottom, of whatever's in the warm water. So heat the water between 100 and 105, fill the container, remove clothing, jewelry, bands, or straps, fully immerse the injured part, and don't allow it to touch the sides or bottom of the container. Continuously stir the water, and if you complete rewarming, gently dry the affected area and apply dry, sterile dressings. Keep the patient at rest. Don't allow them to put weight on the part. Don't massage the part, and keep the patient as warm as possible. Continue to monitor. Treat for shock as you would any shock. Don't allow the limb to refreeze, and transport with the affected limb slightly elevated. Now let's talk about the effects of heat on the body. And heat that is not needed for temperature maintenance, and it's not lost to the environment, is going to create hyperthermia, or too high a temperature. If left unchecked, if temperatures get above 105 degrees, that can lead to death of brain tissue. And there's a variety of different types of heat emergencies that range anywhere from heat cramps, heat exhaustion, to heat stroke. Now with heat cramps, you sweat out your electrolytes. You sweat out your potassium, your sodium, magnesium, those sort of things, and the muscles cramp up. So patients would benefit if they can, or they're awake and can swallow, from a sports drink and maybe massaging the muscle or the cramp. Heat exhaustion is a situation where you continue to sweat. You not only have lost your electrolytes, but you've also lost a lot of volume. You've sweat out a lot of water, so you become mildly dehydrated. And as a result, it's a mild form of hypovolemic shock. In those situations, you want to, remove the patient from the hot environment, loosen restrictive clothing. If they're awake and can swallow, you want them to, drink a sports drink. You want to squirt them down with cool water, fan them, help bring their temperature down so they quit sweating. Heat stroke is a life and death minute-by-minute emergency that occurs when the heat rises extremely fast and the body's unable to dissipate it. This occurs primarily in really hot and humid environments like the attic of a house. or a garage that's locked up with no circulation. The skin is hot, dry, maybe moist. They don't necessarily have to sweat a lot to have heat stroke. They may go directly into heat stroke with little or no sweating. So patients with moist, pale, and normal or cool skin may get heat exhaustion. And as we had mentioned, that's when you sweat a lot and you lose salts, you lose potassium, sodium, magnesium, and you lose volume. And the loss of volume can be significant enough that you can go into shock and you become just exhausted. We see heat exhaustion, particularly in patients who are not acclimated to the heat. If you work indoors all the time in an air-conditioned environment and suddenly you're outside and it's hot and you start sweating a lot, you could have heat exhaustion. Patients with heat cramps are going to have muscle cramps. Heat exhaustion could have muscle cramps as well. They're very weak. They're exhausted. Because it is a form of shock, they're going to have other symptoms of shock. Pale skin, rapid shallow breathing, weak pulse. They'll be sweating heavily, and because it is shock, if allowed to continue, it can cause unconsciousness. Care is to remove them from the hot environment, administer oxygen, loosen restrictive clothing, keep them flat, give them small sips of water or a sports drink if they can swallow, and then apply moist towels, spray them down with water, fan them, and then transport. Patients with really hot skin, whether it's dry or moist, could be heat exhaustion. Could also be heat stroke. And I don't know why they're taking us back through the same slides that we just discussed. With heat exhaustion, because in the later stages, or in the initial stages, it's the result of volume loss. In addition to rapid shallow breathing, the pulse initially is going to be bounding. It's going to be full when you palpate it at the wrist. It's going to be fast, and as volume loss continues, as the patient continues to sweat and water and fluid is lost, then the pulse becomes weak and thready. They're going to have generalized weakness, little or no perspiration because they have none left, loss of consciousness, dilated pupils, or seizures. Here we want to remove them from a hot environment, get their clothing off, apply hot packs, again spray them down with water, fan them, give them oxygen, and transport immediately. For infants or young children, cooling is started using tepid water. If we have a child who has a really high fever from an illness or a sickness, again, greater than 103, 104, 105, we want to bring that temperature down. So we'll put them in lukewarm water or bathe them more with a lukewarm water to try to bring their temperature down. Some other water-related, let's talk now about water-related accidents, which include boating, water skiing, windsurfing, jet skiing, diving, and scuba diving. In these water emergencies, certainly trauma can occur, and during the trauma, we want to treat them just like any trauma patient. Just understand you may be in a very unsafe environment. If you're in the water or in a boat in the water trying to rescue these patients who've had these injuries related to water, they can be a unsafe scene. As a result of trauma, they certainly could have airway obstruction, they could have cardiac arrest. Patients who find themselves in water and had no intention to be there, the shock could cause a heart attack, or a heart attack could cause them to fall in the water. Diving, shallow diving injuries, they could have injuries to their head or neck, internal injuries if they wipe out at high speeds. If they're in water and the water's moving, it sucks heat off the body 32 times faster than the air, so they can get hypothermia while in the water. And oftentimes these activities involve the use of alcohol, which further drives the temperature down as well as alters your thinking process to where you might participate in some risky behaviors leading to your injury. Drowning is something too that can occur. Now, according to the World Health Organization, drowning is the process of experiencing respiratory impairment from submersion or immersion in a liquid. And the issue with drowning is anoxia, no oxygen. You become severely hypoxic. You deplete all the oxygen in your blood, and that's called anoxia. So the treatment for drowning, regardless of whether it's salt water, fresh water, regardless of whether it's a dry drowning, wet drowning, is that we have to begin oxygenating and ventilating the patient as soon as possible. Outcomes from drowning can include death, can include long-term disability from the anoxic brain injury if they do survive, or if quickly plucked from the water or ice-cold water, they may have no long-term disability. Drowning occurs as a person begins to struggle or stay afloat. Again, most people drown because they find themselves in water and they cannot swim. They're going to be slapping the top of the water, flapping their arms up and down in an attempt to keep themselves above the water. When they start to submerge, they'll take that one deep breath. They may get a little water in their airway, which causes them to cough, causes them to swallow a lot of water, and their belly fills up with water. The coughing and the spasm of the larynx seals off the airway. They don't breathe. They can't get any breath in. They become hypoxic. The hypoxia leads to unconsciousness, and they slip under the water and lie on the bottom of the body of water that they're in, most found in a fetal-like position. Some who die from drowning die from just lack of air. And if we can get them out of the water and begin ventilating for them right away, we'll give them their best chance. So in those patients who slip under the water, your need to take a breath is based on the level of carbon dioxide in your blood. And if I'm not breathing, I'm not exhaling or getting rid of carbon dioxide. Carbon dioxide levels increase. The stimulus to take a breath becomes so powerful that if you are unconscious underwater, you will take a breath, which will lead to further hypoxia, unconsciousness, and anoxic brain injury. So you want to begin rescue if you're trained. You want to begin rescue immediately out of the water, and then as soon as the patient is to the surface, begin rescue breathing without delay. If you reach a non-breathing patient in the water, support them in a semi-prone position and start mouth-to-mask ventilations. You may encounter some airway resistance, particularly if the lungs are full of water, but you can overcome that by ventilating them more forcefully than you would other patients. Don't delay transport to the hospital. You also have to keep in mind that if you pull somebody from the water and they're unconscious, that they may have head injuries or neck and spinal cord injuries as well, particularly if alcohol is involved, particularly if there's a history of them diving into the water head first and the water is shallow, or if the patient is pulled from the water following a water slide ride. They may not be able to complete the assessment for spinal injuries while the patient is in the water. We don't want to delay getting them out by doing that type of assessment. Take care to avoid aggravating any spinal cord injuries, but again, don't delay beginning basic life support. Keep the patient's neck rigid in a straight line, the body midline, and then information supplied to the dispatcher or hospital from the scene and during transport is critically important to those providing care. Most diving accidents occur when you dive into shallow water and your head strikes the bottom of the swimming pool, the lake, whatever river, whatever you dive into, um, and the weight of your body is driven down against your head, causing compression fractures of the cervical spine and cervical spine cord injury. Um, Diving accidents can also involve other parts of the spine, can involve hands, feet, ribs, depending upon, if I dive into a body of water without knowing what's in the water, certainly could strike my chest on a rock if it misses my head and have, rib fractures. The emergency care for diving accidents is the same for any patient who suffers trauma outside the water, ABCs. Scuba diving accidents, there are a variety of different types of scuba diving accidents that can occur. One is an arterial gas embolism or gas bubbles in the bloodstream. This can occur from a diver holding their breath. As a diver goes underwater, you can imagine the amount of pressure that all that water above you is putting on your body. You know how heavy a 5-gallon bucket full of water is. Trying to carry that, that's roughly 40, 50 pounds of water in a 5-gallon bucket. If you take your width and depth of your body, standing on the bottom of 30 feet, and you're 6 foot tall, you have a vertical column of 24 feet of water pushing down on top of your body. The weight of that water can cause the gas that you breathe from your scuba tank to turn into a liquid in your bloodstream. And then as you ascend, the pressure is released or let off your body. And that gas then, or that liquid becomes a gas as you ascend. And if you hold your breath and don't blow that gas off, those gas bubbles can get caught in your bloodstream and cause problems. Decompression sickness is another scuba diving accident that occurs. This is commonly called the bends. Decompression sickness, again, occurs from a diver who surfaces too quickly from a deep, prolonged dive below 1 atmosphere. 1 atmosphere is 32 feet. So if I'm diving in 60 foot of water for half an hour or 45 minutes, and I ascend too fast, all those air bubbles don't have time to escape my body through my breathing, and they get trapped in my joints, they get trapped in my abdomen, and anywhere from 1 hour to 48 hours after I'm out of the water, those air bubbles stuck in those areas cause excruciating pain that may even bend you over. And that's why it was called the bends, but it's decompression sickness. Treatment is to take the patient to a hyperbaric chamber where they can recreate that pressure, where they can put the body under that pressure. They can cause those bubbles to turn back into a liquid, and then they can slowly let the pressure off, allowing you to blow those bubbles off rather than have them trapped in your tissue. Signs and symptoms. It's an air embolus is what it is. You can get them in your eyes, which would cause blurred vision or blindness. You can get them in your abdomen, in your joints, which could cause joint or abdominal pain. You could get them in your chest, which could cause chest pain. Air embolisms also, you may have numbness and tingling sensations in your extremity. You may have weakness, even possible paralysis if you've got an air embolus of the spine. You could have frothy blood in your mouth or your nose and convulsions. You could rapidly lapse into unconsciousness and go into respiratory and then cardiac arrest if not cared for. In addition to those bubbles getting caught into your abdomen and your joints and your muscles, they can be trapped in your head as well, causing your brain not to function properly. So you could have personality changes, feel extremely weak or worn out, and then deep pain to the muscles and the joints, causing you to bend over. You may get itchy blotches or mottling of the skin, numbness or paralysis, choking or coughing, labored breathing, all these things as a result of decompression sickness. The behavior of decompression sickness may be similar to intoxication, and I think what they're referring to here is a condition known as nitrogen narcosis. When you get below depths of 100 feet, the oxygen that you breathe has a narcotic effect. And the nitrogen has a narcotic effect. When you're scuba diving, you're breathing air. Air is 21% oxygen, but it's 70% nitrogen. And the nitrogen has a narcotic effect on the brain at that depth. And if the patient were to surface suddenly because of altered mental status from the narcotic effect of the nitrogen, and the oxygen, they could have air embolus, they could have decompression sickness, all those things. So they can have chest pain from this as well. They may collapse or be unconscious. Treatment for scuba diving accidents are the same emergency care steps for any patient, beginning with ABCs. Open their airway. Is it maintainable? High concentrations of oxygen, rapid transport. And, if a diver pops to the surface suddenly, you've got the issue of getting them out of their gear, and then providing resuscitation as well. We used to talk about transporting the diver with a potential air embolus with his head down so that the air would go up to the feet, but that would be putting him in Trendelenburg, and we don't do that anymore. Putting a patient head down, head lower than the rest of their body, puts weight on the diaphragm, and as the abdominal contents rest on the diaphragm, and makes it very difficult for the patient to breathe. So we just keep them flat like we would any patient. Keep them warm, and in the position of comfort, either flat or on the left side or the right side, and monitor them frequently. Water rescues, there's this little thing we talk about that helps us remember the steps of a water rescue, which include reach, throw, row, and go. Reach, hold an object for the patient to grab, throw an object to them that will float, row a boat out to the patient, or go, as a last resort, swim to the patient. And if you're not trained in water rescue, I would highly discourage swimming to a patient. If a patient is drowning, oftentimes they can't see. Now they've got water in their eyes because they're slapping it, they're trying to stay afloat, the hair may be in their eyes if their hair is long enough, and you want to poke them with whatever you're trying to reach them with because they're not going to see it. When you throw something, you want to throw it and hit them so they can feel it. When you row out in a boat, be very concerned. I mean, if they grab the sides of the boat, particularly if it's like a canoe, they could capsize the boat and you could be in the water as well. If you swim to them, again, if you're not trained in water rescue, understand that when you get there, they're going to climb on top of you trying to stay afloat or trying to stay on top of the water and push you under the water and could cause you to drown. So reach, throw, and row, and then go. Ice rescue, the number one rule of ice rescue is certainly to protect yourself. You want to throw a flotation device to the patient toss a rope with a loop. You can push a flat bottom aluminum boat out onto the ice. If the ice cracks, the boat will still stay floating. You can also lay a ladder flat on the ice to help distribute your body weight. Again, if you're trained in ice rescue, that's something you should do. But if you're not trained, even following these steps could be very, very dangerous unless you have the proper training. And in most fire services, most rescue departments, they've had specific ice rescue training. Treat the patient for hypothermia because the patient may not be able to do much at all to help you. If they're extremely cold, their muscles are going to be rigid. They're not going to be able to grab or hold on to anything. Always transport these patients because they will have severe hypothermia. Again, don't walk alone. Don't work alone. Don't walk out onto the ice to try to rescue them either. Now we're going to talk about insect bites and stings. All spiders are venomous. Some will break your skin. Others don't have fangs large enough or sharp enough to puncture your skin. Insect stings and bites are rarely dangerous or life-threatening, but there are those patients who have or may go into anaphylactic shock, particularly after being stung by a bee. So anaphylactic shock is a major concern in those patients who are allergic to particularly bee stings. You want to remove the stinger quickly by scraping it with a flat across the skin with a credit card or something flat to get that stinger out of the skin. We don't want to squeeze it with tweezers because it may continue to further inject the venom from the stinger into the body, which in patients with anaphylaxis could be life-threatening. Your assessment of a patient with a poison bite and sting, like anybody else, beginning with your general impression, level of consciousness, ABCs, and then look for things like noticeable stings or bites, or the patient may tell you that they've been stung or bitten. Look for puncture marks, particularly to the fingers, the forearms, the toes, the legs. Look for blotchy mottled skin, which you might have with particular spider bites. Localized pain or itching in the area of the bite. Numbness in a limb or a body part as a result of the neurotoxic effect of their venom. They may have burning sensations at the site, followed by pain that spread throughout the limb. The limb may be red and swollen and may even blister. The patient may become weak or collapse, may have difficulty breathing, and have an abnormal pulse rate. They may be lightheaded and dizzy as well. They may have the chills, they may be feverish, they may have nausea and vomiting, muscle cramps, chest tightness, joint pains. They may have profuse sweating, and again, anaphylaxis or anaphylactic shock is something that we're really concerned about. In patients who've been stung or bitten, you want to treat for shock, particularly if you're seeing the signs and symptoms. Remove the stinger or the venom sac. Remove jewelry from the affected limb. You can place a constricting band above or below the bite if your local protocol would require you to do so. It's more important to keep the patient calm, to keep the limb immobilized. Those things will spread the venom. If the patient is worked up, moving a lot, if the limb is not kept still, the venom will spread through the system much faster. Snake bites require special care, but they're usually not life-threatening. Death is usually not sudden unless the patient goes into anaphylactic shock as a result of being bitten. Most snake bites they don't envenomate you. They've got to be able to bury their fangs deep into your tissue in order to milk those sacs to get the poison or the venom into your tissue. And most of the time that doesn't occur. They may strike a flat part of your body and scrape the skin, but they don't have a place to bury those fangs. Remain calm, keep the patient calm, immobilize and bandage the extremity is the most effective way to slow the spread of venom. Look for a noticeable bite on the skin, which may appear as nothing more than just discoloration. They may have pain and swelling in the area of the bite, which may develop slowly. taking from 30 minutes to several hours to even show itself, and may progress into blisters, darkening of the skin to full-blown dead necrotic patches of skin, like we see in patients with brown recluse spider bites. Their pulse may be rapid, their breathing may be labored because they may be shocky, they may have general weakness, vision problems, nausea, vomiting, seizures, drowsiness, and unconsciousness. As far as patient care goes, treat for shock, keep them flat, conserve body heat, keep the patient calm, locate the fang marks from the snake bite, remove any jewelry on the extremity because there may be some swelling, keep any bitten extremities immobilized to decrease the spread of venom, and transport the patient for further care. Contrary to popular beliefs, we don't incise the wound, cut the wound open, and suck the poison out. That's just not something that we do. Poisoning from marine life, particularly jellyfish, can occur in a variety of ways. It can occur just by eating improperly prepared seafood or a poisonous organism from the ocean. It also can occur as a result of stings or punctures from this marine life. Fresh water activates the toxins on the skin, which increases the pain as well. So you want to use salty water to rinse the affected area. Some people certainly have heard of using vinegar water or even urine because of the saltiness of most urine to deactivate the toxins on the skin. Okay? All right. So, questions, you know how to get a hold of me, and I'll talk to you soon.